An umbilical cord prolapse is an emergency in which the umbilical cord passes through the cervix at the same time or before the fetal presenting part. This can be a problem because the cord can then be trapped against the baby's body and maternal pelvis, leading to a compressed blood flow to the baby. This requires prompt delivery to avoid potentially devastating fetal outcomes. Diagnosis is made by the presence of a mass within the vagina. It is often accompanied by sudden, severe fetal heart rate deceleration. The nurse must remember that the cord may be occultly or overtly prolapsed. There may be an actual loop extending into the vagina, or the cord may be lying alongside the presenting part, making it unseen. Some risk factors include a premature or small fetus, delivering more than one baby per pregnancy, excess amniotic fluid, a breech delivery, or an umbilical cord that is longer than usual. Prompt delivery has been shown to improve outcomes. This means that cases of UCP should be delivered as quickly as possible, which generally means a C-section unless the provider believes that a vaginal delivery would be more rapid. If spontaneous or artificial rupture of membranes occurs, auscultate fetal heart rate for a full minute and at the beginning and end of contractions. If bradycardia is detected, do a vaginal exam to see if there is a cord prolapse. If the mother is laboring with a confirmed rupture of membrane, she will be kept horizontal, usually in bed, until the baby's head is well engaged and the risk of a prolapse is decreased. After identifying a cord prolapse, the cord needs to stay elevated off the presenting fetal part. This is generally performed manually, with the examiner placing 2 fingers or an entire hand into the vagina to elevate the fetus off the cord. It is also encouraged to administer the mother oxygen via face mask and monitor fetal heart rate. Care should be given to avoid palpation of the cord because that may cause vasospasm, which can lead to worsened outcome. Placing the patient in steep Trendelenburg or knee chest position is believed to be helpful by taking advantage of gravity to further relieve pressure on the cord. Bladder filling is another option. With this technique, a Foley cath is placed and the bladder is filled with approximately 600 milliliters of saline. The patient's enlarging bladder provides upward pressure on the fetus, thus easing the compression of the cord. Another method that has been used to treat cord prolapse is phonic reduction, which is placing the cord back into the uterus by sliding it above the fetal presenting part. This is performed by placing the entire hand in the vagina and gently elevating the fetal head. The cord is then lightly elevated above the fetal head, preferably at its widest point, and replaced back into the uterus. The goal is that the cord should stay in the fetal nuchal region. Another important consideration is keeping the cord moist. When delivery is imminent, this is less of a concern, but with a prolonged interval to delivery, the cord could dry out, which could lead to vasospasm and thus worse outcomes. A moist tampon or 4x4 gauze can then be inserted gently into the vagina below the cord to help keep it in place. All in all, despite the potential for extremely poor outcomes, most neonates born after experiencing UCP do very well, especially if the delivery is achieved within 30 minutes, but the decreased blood flow can lead to long-term disability or death if not treated rapidly.